Okay, hello and welcome to iCHOM webinar series. My name is Zofia Dasgupta and I'll be moderating today's session. It's great to see you, so many of you joining. Please do, if it's first time joining us at this webinar series, please do post in the chat where you're from, where you're dialing from, and genuinely you can introduce yourself. We'd love to hear all great stories. We'll be also looking for your questions. You can post those as well in the Q&A function of this webinar. So please be active on our chat options. Great. So today as well, the team will be presenting some very interesting story featuring one of the iCHOM set, low back pain. If you don't know this set and you want to find out more or genuinely interested how the components of this set are or thinking about implementing it, please, you can follow the QR code on this slide and it will take you to our website where you can download the relevant materials about this set. I would also like to remind everyone that we're approaching end of September, and this is the time where iCHOM team will be meeting again at our annual conference. This year, it's at the Convention Center in Dublin, so absolutely fantastic location. We'll be talking a lot about actual real results and real change for the patients. Can I have a next slide? Our speakers are confirmed, so please do check our website for more information about the speakers and the agenda, as well to book the pass. Here's as well the easy way to follow and find out more about the conference. So please book before the 20th of June to save as well on the registration. Excellent. So thank you so much. Today we welcome the team from the Saudi German Health. I'm actually particularly happy to have you on this call because I actually had a chance to meet you in person quite a few times. So it feels like a little bit easier to have this discussion, even though we're virtually this time. So really great to see you. And I'm really happy that you'll be sharing your experience with our audience. Saudi German Health is a leadership partner at iCHOM. It's also the first and only iCHOM certified accredited hospital in Saudi Arabia so far. And because I've seen already the slides, I know the team will be talking a little bit more about that. And the organization is truly a pioneer in leading the value-based healthcare in the Saudi Arabia. And have, just an example, not only being accredited, but they also conducted 2 value-based healthcare conferences in 2023, 2024, and I think the other one, the third one, is coming this year in November in Riyadh. So my guests today, my 3 guests today are Dr. Mohammed Hussein, who is a corporate director of value-based healthcare. He's a health policy consultant with over 20 years of experience. Dr. Safwat Hashem, who is professor of neurosurgery and director of Neuroscience Center in the Riyadh branch of Saudi German Hospital, and Dr. Mustafa Galwash, who is a group chief quality officer at the Saudi German Health. He's a certified quality trainer, SQ prelim judge for the International Excellence Team Award. So with that, I would like to welcome the team, and the floor is yours.
Thank you, Zofia, and thank you for the attendees. And it is always our pleasure to participate in such events. I would love to thank ISHOM, our great partner in addressing the value-based healthcare and addressing the patient outcomes. And I do believe this kind of series of webinars will be like an excellent enabler for all organizations to be like very clear in their path towards implementation of value-based healthcare. So I'll go to our slides, and as you can see from the title, it is we will talk about our path towards outcomes, and to ensure that everybody will be on the same page, and for our colleagues that doesn't know about Saudi German health. So as you can see from the slide, it is like a well and deep rooted organization started in 1940 by the founder Batarji, and the founder was like focusing on importing different medical devices and the medications. And the series and our like empire of hospitals, which are like one of the largest health groups in the Middle East from footprint point of view, started in 1988 by the first hospital in Jeddah, founded by engineer Subhi Batarji. He is the founder, and his brother Dr. Khalid Batarji. Actually, we continued to have a lot of institutions, including hospitals. We have like 8 hospitals in Saudi Arabia, 3 hospitals in UAE, and 2 hospitals in Egypt. And we are like expanding in Morocco and other cities like Pakistan. We also not focusing on only hospitals. We have like ambulatory care settings, like we have 2, one in Jeddah and one in Abha, and we are expanding in the ambulatory care settings as well. As you can see, it's like an empire that needs to focus on the main objective, or like a slogan of the whole group, and the main slogan is caring like family. So we focus on caring to our customers like a family, and accordingly the patient outcomes, or our customers' outcomes, is one of our main pillars. We have like decades of healthcare leadership. As you can see, we have we served more than 2.5 million patients. We have more than 44 specialties, and as you saw from the previous slide, we are like in 6 countries, and inshallah we will have to be in 10 countries by 2028. To focus on the path towards value-based healthcare, as you know, everything starts by spark, and the main spark of value-based healthcare started by the national movement. And as some of the audience from Saudi Arabia and from the region, but the others are from outside. So actually, we have like a very agile and very ambitious vision in transforming the whole healthcare setting in Saudi Arabia. And there was like a spark by a white paper by CHI, which is the Council of Health Insurance in Saudi Arabia, which is responsible to oversee the insurance business in the healthcare sector. And this actually white paper like have like the roadmap and the objectives of why we do need the value-based healthcare movement, addressing the main pains and the healthcare system by addressing the increased cost of healthcare, and ensuring that the whole transformation will be based on or founded around the main pillar, which is the patient. In addition to this, there was like rising expectations from the community. Of course, it has increased the burden of having more advanced and more focus on the outcomes. Also, one of the, as I said, is one of the pillar is ensuring that we provide the right value to the patient. So the patient, the value that the patient will expect from the healthcare system, but in the same time, we need to ensure that this will address also the cost issue of the healthcare and the reimbursement process in the ecosystem of Saudi Arabia. One of the big issues that even pushed us as Saudi German Health to start this kind of movement. There was no like a structured and inconsistent outcome measurement process, and this is why the first organization that we focused on and focused to participate with and to ensure that we have a proper collaboration with is ISHOM, and this is why we were the first to be like accredited in two different diseases, which is diabetes and low back pain. Next. And of course, to do this, to go into this way, we need to have like a foundation. We need to have a structure. And actually, one of the main success factors in our journey towards addressing the value-based healthcare, we transformed the whole quality framework. We started in 2021 to add the value-based healthcare as one of the pillars of the quality framework in the whole group. As you can see, where we had like quality reviews, patient safety and risk management, and there were like performance improvement and performance measurement as the third pillar. We changed this towards value-based healthcare. And as all of you know, that value-based healthcare focusing on outcome measurement, and I do believe incorporating all of this kind of concept into the holistic quality framework enabled us to have this kind of link between different processes and ensuring that we don't have like any kind of redundancies in addressing the holistic concept of value-based healthcare. To do this as well, we need to ensure that the value-based healthcare as a main pillar of quality framework has also a framework. Framework means you have a well-structured pathway and well-structured processes that enable you by the end of implementing the framework to have this kind of great thoughts, a great concept about value-based healthcare. We started in two phases, as you can see in the slide. The first phase addressing the strategic leaders in the organization, and as you can see, we started by having value-based healthcare leaders, and we have you will listen today to my dear brother, Dr. Mohammed Hussein. He was like one of the founders of the whole concept, and of course we need to ensure that the executive leaders has had this kind of understanding. And always Dr. Mohammed Hussein is referring to the first presentation that were like addressed to everybody, and I do believe there was a lot of new concept that emerged like proms, CROMs, and others, and this presentation was not so easy to ensure that everybody understand the whole concept behind value-based healthcare. To success in this phase, we need the clinical leaders with us, because without the clinical leaders, this kind of establishment of the framework will not get the fruitful outcomes. And I cannot forget our dearest finance team, as you know, because the element of the cost is very crucial to address the value-based healthcare. Our second phase was to ensure that this will be cascaded not only to our branches and our second level, also to ensure that the patient is a core pillar in development and monitoring of the whole program. So we have the second phase, which we had a quality team, of course, as a main player. Health informatics, because we are talking about outcome measurement and cost containment. Everything is we need to ensure that the definitions of the indicators, definitions of data, the platform that we'll use to ensure that we monitor this kind of process is very clear and founded in the health information system and also the data definitions. Patient experience, because as I said, patient is the one of the a major player in the whole development and monitoring of the system, and also the patient themselves to give the feedback and to give us more insights about how to implement this kind of questionnaires, even addressing this kind of gaps in their outcome quality of life outcomes. So this kind of involvement of the patient and patient experience was very evident in the second phase. To ensure that everybody understand this, we have this kind of visual display of the framework. And as you can see, it starts by preparation, then design and implementation, and the third level is evaluation. In preparation, as I mentioned, we need to ensure that the board and the leadership is involved, and the involvement was evident from not even from 2021. I can say that Mr. Makarim, he is our president. He met Prof. Michael Porter, I do believe, 10 or 15 years ago, and this kind of movement was in the eyes of the whole leadership. Create an interdisciplinary value-based healthcare team that will move will do the structure, will move the structure into implementation, and ensuring and everybody is aware of the system. And the awareness session is again a crucial part of the whole preparation, because a lot of new concepts, a lot of new changes in the whole processes to ensure that the outcomes will be like in the eyes of the clinicians and the organization. Also, the fourth pillar of the preparation is to how to select the integrated practice units and the diseases that, inshallah, Dr. Safwat and Dr. Muhammad will focus on it. The design and implementation, we thought that the easiest and the simplest way is to talk about the four main pathways, which is productivity, efficiency, financing cost, and the quality, of course, as the main pillar of the whole thing about the outcome, including CROMs, PROMs, and PRAMs, and also CBG's implementation as well. The third level is the evaluation, and we need to ensure that this kind of implementation will be evaluated on a regular basis by different stakeholders, including the patient. So even the development of the tools, the improvement of the tool, and I do believe that Dr. Muhammad will talk about a lot of achievement or improvement in application or implementation of the tools, and even the translation of this kind of outcomes. Also, one of the key pillars of the white paper was changing the concept of only private provider of healthcare towards population health, which has a lot of meaning and has a lot of impact on the whole processes that we have in our organization, including even how we can see the clusters or the cohort of the different patients into different with different eye. It's not only marketing or sales, it's something to focus on the health outcomes of this cohort in addition to whatever needed to sustain the business. So this kind of changes was very evident. And Dr. Muhammad, I do believe that this slide is very crucial as well. Next slide. And to ensure that this kind of strategic framework will be implemented, we need to go into more granular level of having very definitive framework on disease-specific implementation, which is the next slide. So as you can see in this, it's like a very it's like a literature-based. It's a very scientific-based approach, evidence-based approach, and as you can see, it's well-known like pathway to implement the value-based healthcare by selecting the right medical condition. And of course, today, inshallah, Dr. Safwat will talk about the low back pain as this kind of implementation. So I leave the floor to Dr. Safwat, and thank you for listening to me. Dr. Safwat?
Assalamu alaikum. Good afternoon, everybody. It's a great honor to me to participate in this webinar to present our experience in the value-based healthcare for low back pain. From my side, for a long time, I was thinking about the real value for the patient. I practiced neurosurgery for more than 20 years. Usually, my question: what is the real value for the patient, and how can provide the best with complementary service? When I came to join SGH Health, I met Dr. Galwash and Dr. Muhammad Hussein and the quality team in SGH Health. Actually, they started to speak about the value-based healthcare, and they started to read. So I find that it meet my expectation, and it will answer a lot of my questions. When we started to work with Dr. Muhammad Hussein, actually, he gave me great ideas and knowledge about the value-based healthcare. And when we start to implement this, we should select one disease. So we're starting to look after our cases, and finally we selected low back pain. So, but why we selected low back pain? We selected low back pain as a first step because multi-discipline are needed. Also, there is sufficient volume in our hospital. In addition to, it is aligned with the hospital priority and vision. Also, there was a clear medical leadership and a clear improvement cycle, and also the team has relevant knowledge. During step one, after we selecting our disease, which was the low back pain, we started to select patient. What is the inclusion and exclusion criteria? We include all patients visiting the outpatient complaining of low back pain, with exclusion of some category. All patients less than 18 years old has been excluded because they are considered a pediatric age group, which may change outcome. Also, we excluded other specific cases for the low back pain as patient with spinal tumor, spinal trauma, spinal fracture, or congenital scoliosis, because it will affect also the final result of outcome, and you concentrate on all other patients. Next. Next. After that, we starting to nominate the IBU member, or integrated practice unit member. We saw that the unit or the team member should include all parts involved in this process, which include physicians, nurses, physical rehabilitation therapist, dietitian, radiologist, pharmacist, and patient educator. Regarding the IBU, there is two models can be implemented: the co-location approach or care integration approach. Here in Riyadh, we followed the co-location approach. Actually, because of support from the Riyadh leadership, we succeeded to have all the members in the same area, which facilitates the patient journey and the communication between the team member to provide the healthcare. Why it is not, if the physical is not available, also we can concentrate on care integration approach, which is followed in other branch in SGH Health in Asir. Next. After that, we went to step 2, which is the care delivery value chain, which is the most important step in our implementation. During this step, we identified the stages of the stages of the care for the patient, which includes the preventing stage, diagnostic stage, preparing stage, intervention stage, recovery stage, and the monitoring stage. For each stage, we identified certain points and certain questions we should answer, and the patient and the team should know what they will do for each stage. These 4 questions include: what do patients need to be educated about, which is the engagement of the patient in our process? Then, how can what we will measure, and the access point, where do the patient care activity take place? And finally, the care delivery. What activity are performed at each stage during the delivery value chain? Next. One of the main item in care delivery chain is in low back pain is the patient engagement. In our protocol, patient engagement is very important and a crucial point in our program. Patient family engaged is a strategic priority. For this, we have already now in the hospital the patient and the family advisory council, which is held on regular basis. Also, we engage the patient and their family in the decision making regarding their treatment and the care plan. And we created an initiative of Ask Me 3, which involved please ask me 3. What is my diagnosis? What's my treatment? And what's my alternative? Also, in our stage of patient engagement, we are timely and open disclose harmful adverse event. And we are following the evidence-based practice to prevent the healthcare disparity and promote patient safety. Next. Then we come to the stage 3, which is measuring and relevant patient outcome. For measurement, we should have measurement applicable measurement tool to evaluate our work and to evaluate the patient. But we need to evaluate and measure from the clinician perspective and from the patient perspective. So we concentrate on clinician reported outcome measure, which involves the mortality, rehospitalization, reoperation, and rate of intraoperative complication. Then we go to the patient-reported outcome measures, where we are using EQ5D 5L form, and the ODI, the West Disability Index form, and the pain intensity. And finally, we went to the BRIMS, or the patient-reported experience measure, where we are using the Brisgani survey. One can ask why this measurement or scales. Actually, to select a certain measurement scale or appropriate measurement scale, we went to the ICOM website, where we can comprehensive set of priority of the outcome and the proposed minimum set of outcome. Based on this site, we selected this measurement outcome. Next, please. And this clarify how we are collecting and analyzing the data. The medical team collects the data. Then the quality team makes the data entry and the data analysis. Then the medical team will do the follow-up. And this is the example of our forms for evaluation. Go back again. Next. After we collecting the data, we will do stratification of the condition and to calculate the time-driven activity-based costing. Why our stratification will help us too much for conclusions. We're stratifying the patient and the data based on the demographic factor, clinical factor, socioeconomic factors, health-related behavior, and the personal and the family choices. This is example how we stratifying the data. As we see in the slide, we are enrolling a patient according to the time, demographic distribution of the patient, and also depending on the service, as we stratifying the patient into patient with back surgery and the patient without back surgery. Even with patient with back surgery, we stratified the patient according to the procedure we did, whatever the discectomy or fusion. And also, according to our data, we calculated the mortality and the reoperation, inter complication, readmission within 30 days, and the readmission within 90 days. Next. And this form will, it's very clear that the outcome of our patient, as we are measuring the baseline quality of life in the beginning of the treatment, after 6 months and after 1 year, and as we see, the average quality of life improved during from 6.8 to 7.3 after 6 months to 9.8 after 1 year. And from this slide, I will keep Dr. Muhammad to complete our presentation and lessons from the low back pain care. Dr. Muhammad, the floor for you.
Thank you very much, Dr. Safwat, and thank you, everyone. It's again a pleasure to present to everyone here, and I can see the list of participants are from different countries, and pretty much sure that they are at different levels of value-based healthcare implementation. Luckily, I was happy to visit different countries in across the world during the last few years, and being exposed to different levels of implementation and different ways of implementation. And I can say there is no right or wrong way, everyone trying to do their best, but there are lots of commonalities between all these countries. And one of the common principles that value-based healthcare is something making sense. However, if you need to succeed in implementing the different principles of value-based healthcare, you need to do it meticulously, and you need to do it in a consistent method. This could explain why we have chosen to start the implementation by developing a framework. Actually, developing a framework in Saudi German Health wasn't something luxury. It was truly important to ensure that different pillars of value-based healthcare incorporated together in a streamlined way. Then different practices can be linked and can explain this framework. And when it comes to the implementation, as thankfully Dr. Safwat mentioned, even at the implementation, it can't be just done in a sporadic manner. It should go also in a sequence. And as explained by Dr. Safwat, the initial step in that sequence is to select a medical condition. Actually, I can say this is one of the most important points, and this is the first point for a simple reason. If you don't dive deep into a condition level, you will spend your days talking about value-based healthcare, but do nothing about it, as if you are talking about weather. But to have a true implementation, you need to be patient. You need to go deep into a condition level in order to ensure that you are reaching outcome. One of the common thing also, I have seen it in different countries, that value-based healthcare making sense. If we go back to 1999 to the Institute of Medicine and to look at the definition of equality was defined by the Institute of Medicine in 2001 as to what extent healthcare services we provide to individual or population reach desired outcome. And I can tell you, this definition was and still the best definition for equality for a simple reason. It links the performance you do with the outcome you got. And the implementation or the translation of this concept was easy when it has been translated into what we call it currently value-based healthcare. It's not something new, it's something logical. It's where you shift your focus more on outcome. There are lots of enablers and challenges we have experienced during our journey in the implementation of value-based healthcare. But before I tell you about our drivers and challenges, I would like just to complement the discussion by Dr. Safwat on something called review. How did we encourage ourselves to sustain the movement of value-based healthcare? Actually, it has been taken into different levels. So, for instance, in our scenario here, and we are presenting low back pain, but the same has been replicated into diabetes, pediatric asthma, and some other conditions. So the same technique, we select a condition. After selecting the condition, after specifying the inclusion and exclusion, we go into the second phase where we start building our integrated practice unit. Now, having this step is important. And the most important point here, once you form your integrated practice unit, is to have or to define patient journey, is what we call it care delivery value chain. But I don't want to repeat, but after you start the implementation, you need a control system to sustain the performance gain. Otherwise, you will end up doing it again. So what have we done? We have confirmed multiple levels of control and review for the implementation. Was it successful from the first shot? The answer basically was no. We have tried several ways in order to have a true value at the patient level. So this is how it goes. At the condition level, we have translated the review into something ongoing. So members of the integrated practice unit, they have kind of daily, almost daily, ongoing discussion between each other. Now, in one of our branches, we managed to do what we call it co-located IPU, where the reception desk, nursing office, medical office, the dietitian, and the physiotherapist were located very close to each other. So that would big time improve the patient experience. In addition to that, even those who will be treated medically require kind of radiological study and laboratory study. We managed to locate the laboratory phlebotomy area and the radiology CT scan, MRI, and X-ray in the same building, and the patient has a very easy access to that. Now, communication between different members of IPU was something ongoing. One of the beautiful things that I liked also in this interaction within the IPU, that the initial nursing assessment being utilized by the physician and the physician care plan being utilized by the physiotherapist, etc., etc. So this was kind of ongoing for all patients. Also, another level of review at clinician level, at departmental level, kind of monthly review for or to answer a simple question: where are we and where are we heading? And that was kind of analysis for the PROM result, analysis for CROM result, identifying areas of improvement, identifying gaps, and accordingly building action plan to cover these gaps and continue the journey, having more progress at hospital level, and particularly in what we call it medical executive committee, the discussion of different, so here at departmental level, the discussion for that condition specific for that department. But at hospital level, in the medical executive committee, we have taken the chance to see the progress of multiple conditions in multiple departments, as well as we have seen also another 2 levels interchangeable for review between clinicians and patients. And I need to here to state something, probably one of the challenges that you are experiencing or you would experience once you start. The question is how to get the most use and benefit of utilizing the results of CROMs and PROMs. Otherwise, your action plan and subsequent improvement might be delayed. Actually, when it comes to PROMs in particular, the best way to utilize the results of PROM is when you have it direct at the bedside, direct at the clinician table, where this kind of subsequent discussion goes between the clinician and patient immediately upon the encounter between patients and the clinician. We are still trying to improve this area, but we are trying also to utilize the data. And I'll give you some advices here by the next slide on what to do if you are currently unable to have such data readily available at the desk level. And as you know, in Saudi Arabia, the implementation of value-based healthcare is yet to be maturized, as the different bodies here working on some of the national initiatives in terms of data collection, data analysis, and defining what should be selected and how it should be selected. We are, I can say, literally speaking, compared to other healthcare systems, we are in a good shape. The journey started around 6 to 7 years back, and hopefully by the end of this year, we will start to see tangible impact. And I can tell you, change is not something easy. It requires some time, particularly when it goes to the national level. Was it easy? The answer is no. We have been hammered by several hindrances during our journey. I'd like just to highlight here 4 of the main enablers and 4 of the challenges. Leadership support was unlimited. Listen, guys, and we have learned over years in performance improvement, the problem in communication. So we used to say it's communication, communication, and communication. But in value-based healthcare, I can tell you the problem always in leadership. If you are lucky to have a supportive leadership, similar to our case, I can tell you one of the most important enablers in the value-based healthcare journey is leadership and leadership and leadership. That was a true enabler at all levels, from the level of chairman until the frontliner staff. Another enabler was defining care pathway. So, and this is a key message here. If you want to be successful in implementing value-based healthcare, take some time, build and define clearly your care pathway. Dr. Safwat spend around 20 seconds in one of the slides talking about the care delivery value chain. But I can tell you a nice story behind developing this value care delivery chain. It was created by a collaboration of around 14 neurologists and a neurosurgeon, in addition to some other stakeholders, nurses, physiotherapists, clinicians from different angles. They came together to come up with this care delivery value chain. Was it really something sophisticated? No, it wasn't sophisticated, yet it was extremely important to define at phase 1. Another enabler that we can't overlook is ICHOM dataset. So if you ask me, how was it easy to select CROMs and PROMs? I'll tell you basically and clearly, we were informed and inspired by accessing ICHOM dataset. And when we selected the low back pain as one of our initial condition, we have gone through an extensive review for the dataset published on ICHOM website. Another enabler is the data analytics solution. And here, I'll give you a simple message here. While implementing value-based healthcare, you need lots of tools. Being automated and using analytical solution will help you big time in speeding up the process of data utilization and scaling up the implementation at a hospital level or at corporate level even. Now, if we look at the driver side, as we see, these were not the only driver, but these were the 4 most important. On the other hand, there were some restraining factors making kind of challenge when it comes to the implementation. The first one here is the workforce readiness gap. To understand workforce readiness, our staff were not ready to being told PROMs, PREMs, CROMs, IPU, value-based care delivery chain, etc. All these concepts, if you mix it together and if you start to use jargon statements and acronym during launching phase, you will have no engagement from your frontliner staff. So that was a challenge. And we overcome this challenge by conducting several value-based healthcare workshops and training session in order to demystify the concepts and principles of value-based healthcare. Also, we have overcome this by early engagement of clinical and executive leadership. We utilize different models of change management. So some of the leaders who attended the first session, they left the session almost with zero understanding. And now I can tell you, we reached the level that our leaders, using the value-based healthcare terminology almost in every single meeting. And this is something truly good when you see medical physicians and medical leader talking about the results of CROMs and PROMs on their day-to-day operation. Another gap, was and still, is cost accounting complexity. Regulatory and coding gap. Now, the best way, as you know, to overcome the regulatory and coding gap is to fill this at national level. And I can say at the level of Saudi Arabia, different stakeholders here in the country, they have taken a brilliant and excellent steps in filling this gap by having a clear coding system and the clear rules of implementing value-based healthcare. What we have done from our side, we start partnering with those regulatory bodies and insurance and payer to align coding structure. Although it's not mature enough, but it's good enough to start with. Also, not to have this as an unanswered challenge, we have start finding alternatives to capture outcomes accurately. Another challenge was cost accounting complexity. And I can say this frankly and clearly. This worldwide still need to be, the maturity of cost accounting complexity is yet to be more investigated in order to have a clearer path for the implementation. One of our successful factor, and it was challenged at the beginning, is how would I count everything? Our solution was by using a time-driven activity-based costing, where we translate all activities into cost in order to have a balance. Because as you know, value would be good enough if you improve the outcome, but simultaneously you maintain or reduce the associated cost. During our cross-functional finance clinical team mapping, we utilize the time-driven activity-based costing to a maturity level that now I can say it clearly, we are ready to go into next level of having different value-based healthcare contracts with different regulatory bodies. And last but not least, challenge patient engagement. To be honest with you, we have launched multiple initiatives to overcome this. And I can tell you from our experience in Saudi German and probably the same in other hospitals, there is no magical solution to get patients engaged. You need to keep trying using multiple initiatives to have the highest level of patient engagement. Here, I can give you some examples that we have done. PROMs, most of the published PROMs were in English. We have translated PROMs into something understandable, and we embedded this in the clinical flow. As well as mentioned by Dr. Safwat, we have launched for our outpatients an initiative called Ask Me 3 to get the feedback and get those patients involved in their care delivery value chain. Even for inpatients, we have utilized another internationally recognized initiative called What Matters to You. This initiative was also good enough to get the patients engaged in care delivery value chain. The message here, choose whatever you want, but don't neglect the importance of patient engagement. And if you want to engage patients, you have to engage them at the design phase. Don't delay it. Now, the last step here, when we translated the PROM, we were cautious to understand if this is something was really helpful, and we would like you to see some of the feedback we got from some of our patients.
هلا أكيد العلاج أكيد رح يأثر علي بالحياة الاجتماعية والعمل وتأثيري بالحركة، حركتي ترجع زي أول إن شاء الله، وإن شاء الله إنه العلاج رح يجاوب.
لا الحمد لله أفضل بكتير عن الأول. الوضع تحسن يعني بنسبة هنقول 90%. أنا الأول ما كنتش بعرف أمشي خالص، كنت فقد الإحساس تماما برجلي الشمال. دلوقتي بقدر أتحرك أيوة باستخدام عكاز، لكن بالتدريج إن شاء الله الوضع هيتحسن أكتر وهستغنى.
هسا الاستبيان اللي عملته تقريبا أكثر من 95% النقاط كلها موجودة.
تماما مطابقة تماما لكل حاجة أنا بمر بيها في خلال تجربة العلاج أو مرحلة العلاج اللي أنا مريت بيها مع الدكتور.
هسا الاستبيان كثير ممتازة كانت وسهلة الفهم لأي شخص عادي، يعني ممكن يجاوب عليها بسهولة.
ده واحد من العوامل. اللغة كانت كويسة، مباشرة، واضحة، بسيطة، مش معقدة، مطابقة للحياة اليومية والأنشطة اللي احنا بنقوم بيها يعني.
إجاباتي على الاستبيان أكيد إن شاء الله إنه راح تساعد في علاجي، وكمان يكون استبيان مساعدة الآخرين فيما بعد العلاج.
أكيد، لأن أنا يعني في حاجات معينة بذكرها في الاستبيان أو بعمل عليها صح أو غلط على حسبها بتتحدد. الدكتور بيغير الخطة، مثلا يقول بيشيل حاجة وبيحط حاجة، بيشيل علاج بيضيف لي علاج. طبعا أكيد.
لكن في نقطة اللي هي القيادة لفترات طويلة اللي هي أكثر من ساعتين في السفر، هاي لو تذكر بالاستبيان تكون نقطة جيدة لي والشريحة نفسها اللي بتعاني نفس المشكلة.
والله مشكلة الحياة اليومية دي إن هي في نقطة ما تذكرتش. يعني أنا عندي مشكلة مع المواصلات العامة، مع ركوب الباص مثلا، أو في المطار لما باجي أركب الباص، أو الدرج العالي، دي ما تذكرتش في الاستبيان. لكن بقية الاستبيان كان واضح تماما وبيغطي أجزاء كبيرة جدا.
So as you can see, we are still up until today trying to learn more and more from the feedback we get from our patients in order to maturize our framework of implementing value-based healthcare. The journey is yet to start, and I can tell those people who think that we are still not seeing everything. Yes, that's a fact. You're not supposed to see everything happening in such short period of time. It's coming step by step, and with time that you should start, and you should start at one point, and with time you will start to see more tangible impact. But do not overestimate or expect to see a brilliant, excellent, awesome result in such a short period of time. In our journey, we have started almost in 2022, and I can tell you during these 2.5 years of implementation, we are very happy and lucky to be the first and so far the only accredited hospital from ICHOM for the value-based healthcare implementation. And you know, we are not just happy because we are the first. No, we are happy because this trigger many hospitals in our area to start looking at ICHOM dataset and start the implementation. And I can use this webinar to say we are always open because any benefit or any lessons that we can share with our colleagues, with other healthcare provider, will subsequently end up improving the life of one of our patients. In our last slide, there are a few lessons that I want to share with you. Culture change is critical. This is a fact. And when you start working on change culture, I highly advise you by changing the culture between the leadership. And you need to categorize your leadership into innovator, who are willing to support your journey. And those resistors, there is another way to handle them, but always to make sense of your change of the culture, link the value-based healthcare to outcome. The second message here, team collaboration is key. And that this could explain why we always start by developing kind of integrated practice unit. And from the title, you can say integrated. That means we need collaboration from different keys. Don't develop or work in silos. Don't include only physicians. Don't focus only on cost. All these should come together. Data drives trust, and this is fact. We always say, in God we believe, all others bring data. So we just believe in God. Everything else need data. And the same, it goes to value-based healthcare. If you want to see that you are moving in the right direction, you need data, which will subsequently be translated into a trust in your data. And what gets measured gets noticed. What gets noticed gets acted on. What gets acted on gets improved. The fourth message here, you need to define the care episode clearly. And this step, for the third time, I'm highlighting the importance of defining your care journey, because all subsequent activities and measuring outcomes, it also linked to the specific episodes or milestones in the journey itself. The fifth message here, start small, scale smart. Saying we want to implement value-based healthcare leads to nothing, trust me. You need to start small. You need to start on one condition and be selective in that condition. Then you learn from this condition and you start to scale it up. It's a capital mistake to start big from the beginning by selecting 10 or 20 medical conditions to work on it, because your efforts will be diffused between different teams. So start small, then you scale it smart at hospital level or at corporate level. And this is exactly what we have done. We start with simple single condition, then we start scaling this up until a moment, as we speak now, we have around 12 medical conditions being selected. The last message, but also important message, technology is important, but not necessity. What I mean here, don't wait until you automate. As simple as that. Don't wait until you automate. You can start by something handwritten. You can start with paper-based. With time, you can maturize this and you can start automating your steps. Because if you have been given a chance to start with paper or to just sit and wait until you have fully automation of your system, probably you will be sitting for a long time. So technology, yes, important, is one of the driver, but you can start without it and you can capitalize it during the journey. This was our successful story. One of the stories actually, but for the limitation of the time, we thought that sharing this with you would at least, particularly for those who are planning to start implementing the value-based healthcare, we hope that you have got some of the messages of where to start and how to start. Before I conclude our webinar, I want to just to thank ICHOM for giving us this opportunity to share our experience, and I would like to thank my colleagues, Dr. Mustafa and Dr. Safwat, for sharing me presenting this successful story. And I yield back to our colleagues in ICHOM. Thank you very much.
Thank you so much, and thank you for sharing this great story with us. We're going to move now to my favorite part of the webinar, which is answering the question from our audience. And I've been trying to do a good job as a moderator, reading the questions. So to our audience, please do, if you have question and you haven't posted it yet, there is a Q&A function on the webinar. We will try to go through as many questions as we can. If we haven't have ability to answer your question after this webinar, we will be collating all the questions and posting the answers later to you. So one way or the other, you will hear the answer. So I'm looking, I think there are a few buckets of questions here from our audience, and I was kind of not sure where to start, but I feel like maybe let's start with the first part of this presentation, Dr. Mustafa, about like how you set it up, how you started in the culture. I think there have been questions around, you know, bringing the staff on board for it. The question here is, you know, were people competing for these roles or have to be asked to do it? So what was the process?
Thank you, Zufri. And as Dr. Muhammad said, and as we started with, the leadership support was one of the fundamental of the whole journey. Staff involvement, as everybody knows, if people doesn't understand well or doesn't have the full picture about the value-based healthcare and how this can affect their day-to-day operation, or even have understanding what is in it for me, the engagement will be like very difficult at the start, the beginning. But with time, with awareness, and with have clear outcomes towards our patients and our processes, and ensuring that all of this kind of holistic concept will be implemented into something valuable for the staff and for the patient, I do believe that now a very high competition in addressing or being part in the value-based healthcare movement is very evident in our organization.
Right, thank you so much. That's really encouraging to hear. And I'm looking at the questions. I feel there are some people in our audience that are really thinking about actually starting the journey as well. So I'm sure that it's helpful. We have a number of questions around the prompts. So let me first ask, you know, you've used the ICHOM low back pain set, which has obviously endorsed set of prompts questionnaires. Were there any adaptation or localization needed for the set in the context of you know, your patients? I mean, I think that the testimonials you shared from your patients that short video was absolutely fantastic and really reflected that a lot of what was asked, it was what the patients were experiencing. But is there anything you can share with us around you know, adaptation and localization of those questionnaires specifically in your context?
Thank you very much. I'll go for this question. Yeah, that's true. And people working closely in value-based healthcare, they will always, particularly when it comes to prompts, they will always feel this challenge. Two of the main challenges actually were language and cultural differences. In our case, if you look at ICHOM, I mean, we were informed by ICHOM dataset because I'm looking at the question, so I'm trying to answer more than one question in my shot. We were informed by ICHOM because we believe that it has been created not only by ICHOM, it was created by large consensus group from across the world. So when it comes to defining when prompt should be collected, the answer is clear and it's already written in the ICHOM set. Now, when you are in doubt which prompt should be selected, also you will find different suggestions from ICHOM for some of the validated tool. Nevertheless, still there are some cultural limitation for some questions, and probably also you will need to have kind of a few adaptation related to the language, because it's a capital mistake to make only translation for the prompts. So for example, when we have selected EQ5D5L as a generic tool, we have found a validated version of this tool in the context of Saudi Arabia. But when it goes to a Swiss Disability Index, we were unable to find something localized here. And what we have done is we translated the questionnaire, and we have went under a validation process by ISPOR methodology, which is translating and translating back. There is a well-utilized, easy-to-use, materialized method to do this translation. So it's not a matter of someone sitting in the office do translation. It's not a Google Translate. It's official translate with testing, with translating it back to ensure that the questionnaire are clear and understood for those patients who would utilize this tool. Now, how about culture differences? Yes, listen, we are on the journey, and we understand that some of the tools, and I can give you 2 examples here. When you look, as long as we're talking about low back pain, when you look at the question of low back pain, there is one question deeply discussing the sex life. And when we start using the questionnaire, particularly for the population of female population, it wasn't easy to endorse such a question to them. From our, let's say, academic background, we know for a fact that it's not just easy to go and delete an answer or delete a question. So what we have done is we did it both ways. We start collecting the data, we have taken off the question, and we start doing analysis for the validity of the questionnaire after deleting this question. So, and this is a message that, yes, you will be faced with such cultural challenges, but please don't make it as easy as you just delete a question or add a question. When you use a validated tool, you need to respect the implementation of that tool. I hope that I have addressed the question.
Thank you so much. And yeah, I think it was very clear. And thank you for sharing. I know, there are lots of hospitals, providers, in your region, but also in other regions across the globe where really that language and cultural nuances are really, really important. So it's great to see your journey here. I have a question to, I think, Dr. Safwat. Someone here on the audience is asking, well, commented as well, maybe, so saying that improvements in quality of life outcomes for low back pain seem amazing. Was this expected? And have you seen any similar results at other hospitals? Or have other healthcare providers, asked about this? And well, actually, there's a question about the cost, but I'm going to park that because we have all sorts of, I think, a number of questions about the cost. So let's just focus first on outcomes. And this is something you were expecting. And I think there was one other question I saw as well, someone asking about comparing your outcome data with other sites in Saudi German hospital group.
Thank you for the question. Regarding this outcome, actually, it is better than our expectation, and this can be explained because we providing the patient with multi-ceremony. We have all the aspect, the physical therapy, the medical treatment, the surgical treatment, and in addition to the pain management. For surgeon or physician who involved in the management, you feel that you did a great job, but actually you need to complete the job by doing the physiotherapy on rehabilitation or to use the pain management. So our result is very good. In comparison to other hospital, even this result, I have an old research, it was published on 2016. Actually, this result is better than my own result because this result is depending on all the aspect of the treatment, not only the surgical treatment. But according to my knowledge, until now, I didn't read value-based healthcare outcome for low back pain from the near hospital. So for my knowledge, I didn't see this to compare data with other hospitals in the current time. But
excellent. So these were both inpatient and outpatients.
Yeah.
Excellent, thank you. I want to just one more question around PROMs. It's, can you comment on your response rates when it comes to the first and follow-up questionnaires? I don't know who would like to take this question.
I'll take it. Thank you very much. Thanks for the one who asked this question. Now, let me tell you from the background of being a researcher, using a questionnaire is one of the challenges. And when you throw a questionnaire for a number of patients, do not expect a very high response rate. When we started initially, the response rate was 3%. Now, that was during the first few days. Then we realized that there is something wrong, either in the administration or in the collection. So after investigation, we start seeing what went wrong during the administration of the questionnaire, and how can we improve that. Now, with such analysis and improvement, we reach a level of around 43% in some of the condition. And keeping in mind that we are currently using around 18 different PROMs tools, generic, disease-specific, and population-specific. And I tell you, reaching this number, 43, wasn't easy. Someone might say, only 40%, that's too low. No, it's not. From the research perspective, selecting and collecting such questionnaire is not as easy as you think. So if you manage to go to 40, 45 in some of the tools, this, I think, and I believe it's a very good number. And keep in mind, we didn't reach this number easily. We went into reminder, simplifying the language, giving different tactics actually to reach this number. And I can see here in the slide another question. If for the sake of time, Sophia, if you want me to tackle another question,
please do. Yes.
Yeah. Because there is a question here on it seems that PROMs and PREMs were collected by medical staff through face-to-face interaction, and the answer is no. It's not always the case, unless if we have a patient with a clear misunderstanding of the question and they require us for analysis, then we do it as face-to-face. Otherwise, most, if not all, PROMs questionnaire are self-administered questionnaire. If you make such face-to-face interaction, you might mislead your patient. Give the patient the chance, write it in a simple language, make it understandable, and give the patient chance to answer it from his perspective. That's much better than making it face-to-face. And when it comes to PREMs, we are contracting with a third party who's obliged to collect PREMs, so we have nothing to do with PREMs data. We are just taking the result from our independent third party. That was another question. There is one more question here talking about the interaction with the payer. If we went back to slide number 9, during the implementation phase, we have presented a strategic framework and implementation framework. In the implementation framework, the last step was to look at the cost. We're not underestimating the importance of cost and involving a payer, but we are saying, before you approach and you start discussing deals between provider and payer, you need to have a clear infrastructure for the value-based healthcare in your organization. What we have done We have built an infrastructure for CROMs. We have built an infrastructure for PROMs. We start collecting data over years, and we start educating our staff. We start formulating integrated practice unit. We start sending some messages for the patients. We start seeking feedback from the patient. We start to maturize our system of value-based healthcare internally. We reach a level now where we can go and advise our colleagues, our healthcare provider, and simultaneously, we start discussion with the insurance company about our data. Now, I'll give you, I can't give you full details, but let me tell you how the discussion goes. The discussion goes with, let's select limited number of conditions or one condition. And we have done this ahead of time. Let's select some patients. We can't go for all patients. And this is what we have done. For example, Dr. Safwat, he mentioned low back pain. During our first meeting with payer, we said we can't include everything. Let's be specific. You know, let's exclude trauma. We have done it already because from the beginning, we excluded the trauma. Let's exclude spinal infection. We did it because when you go with something solid, with something literature-based, and you utilize IHM sets, you will find things are moving smoothly, even during discussion subsequently with the payer. But the message I want to say here, listen, it's your right as a provider to have a clear contract with the payer. But keep in mind, it's the right for the payer to have an access to some of your numbers. So this kind of transparency between provider and payer, if you fail to do it, then you won't be able to go ahead with any value-based contract. Now, we reach a good level of this understanding, and if I have been given 20 seconds to say a few important points when it goes to a discussion between a provider and payer from our experience, don't mess to define well the inclusion and excluded population. You need also to define well included and excluded services. You need also to define well included and excluded complications. You need also to define PROMs and CROMs and the way of collection, measure, and view. If you fail to incorporate these 3 or 4 principles, in addition to some other, but I don't want to just list everything in the literature here, but these are most important in order to have a platform where you can discuss further with the insurance company. I'm sorry, I'm taking a long time.
That's okay. Thank you so much. I think when I was looking at the question, we had quite a few people asking specifically about, how you work with the payer, with insurers. So I think that the takeaway message is to really focus on generating high quality data that then you can leverage for these conversations. Any comments around the cost? Is it something you've been looking at? I mean, you have clearly improvement in the health outcomes for the patients. Are there any indication around the costs?
Yeah, so and I'll take this to Dr. Muhammad, then you can continue. But actually, cost is one of the major elements in the formula of value to our patients. And actually, as I said, now we are part of an ecosystem, and this ecosystem has like a very good steps into transformation and ensuring that this kind of value-based healthcare will be easy for the provider and for the payer to implement. And as Dr. Muhammad Hussein said, always without this kind of reimbursement change, I do believe that all of this effort will be like very difficult to be implemented. So we have like adopted activity-based costing, and we can have like a cost for each movement of the patient, each activity. And this enabled us first internally to ensure that we can even benchmark different activities and ensuring that the only value added steps for the patient journey is included in the value chain for the patient. So we can compare OR minutes, we can compare length of stay, we can compare whatever needed in the specific disease by the specific criteria, and ensuring that you with a contained cost we will get the same outcomes, or the appropriate cost we will get the outcomes. For the ecosystem, of course, we have because we are changing towards value-based payment, different reimbursement models like bundle payment and others. Of course, we have a good relationship with payers. We have very now near to be finished a bundle payment contract with one of the big payers in Saudi Arabia. In addition to have the movement with a regulator like Council of Health Insurance, and they started to have this kind of movement towards a bundle payment in some chronic diseases, in addition to some episodic care procedures and others. So this kind of cost element is very crucial in the whole formula, and having the right data analytics, as Dr. Muhammad said, to ensure that you have a very easy system to pinpoint the areas of the cost issues for the whole procedure, will enable you to ensure that you have good outcomes for the patient, in addition to contain the cost that will increase the burden of the whole ecosystem, and even for the fee-for-service payment model for the time being.
Excellent, thank you. I thought there's a really good question here. I really like that one, actually, and I will combine it with my question I had to you as well. So how do you sustain the momentum, and how do you move from initial success to the high-level success? So raising benchmarks, and what is the right time to raise your internal benchmarks of success? And my follow-up question with that is, do you have plans to expand to other ICHOM sets or clinical areas?
Yeah, again, thank you for the question, and I'll try to tackle multiple questions during my answer. Now, one of my messages in the last slide is start small and scale smart. And in this, I can say, when it comes to sustain the gain, one of our advice is to start small. And I can tell you the maturity level, you can't say I start small in value-based and now I'm mature in value-based. It doesn't work this way. You need to start small in terms of CROMs. You need to start small in terms of PROMs. You need to start small in terms of the number of selected conditions. And when you scale up to sustain the performance gain, you need to ensure that you are scaling up in every and each principle of value-based healthcare. Let me double click here on our case, which is low back pain. When we started in targeting those patients with low back pain using only generic tool. Now, with time, we introduced a disease-specific tool in addition to the generic tool for a selected number of conditions under low back pain. With time, we expanded the list to ensure that we are aligned with the international literature as well as ICHOM sets. So we get maturation over time in terms of PROMs. Now, if it goes to CROMs as well, I remember that we have started measuring the outcome of low back pain using only two clinical indicator, only two clinician-reported indicator. And I'm not saying more KPIs or more CROMs are better. No, what I'm saying is with maturity, you ensure that you are measuring the outcome from different angles. So instead of just focusing on, let's say, mortality and length of stay, you start scaling it up by focusing on reoperation, length of stay, surgical site infection, etc., etc. So you start looking at the outcome also from different angle. Again, when it goes to the condition, also to sustain the gain, please don't move from one condition to another unless you are sure that you have got a good outcome to start with. I'm not saying that you are exceeding the benchmark. No, and this is what we have done. For each of the clinical related or clinical reported outcome measures and patient reported outcome measures, we have selected internal target. We did a benchmark internally between our branches only. But there is a future plan to do external benchmark? Yes. Is there a plan to expand low back pain? Yes, because we started with low back pain, then low back pain and diabetes, then low back pain, diabetes, and pediatric asthma. And the journey is to expand more and more and to use more item sets in the future.
That's excellent to hear, and I look forward to our collaboration. I'm looking at the time, and I feel like 2 more questions, and I have one question to Dr. Savvat. I know how important it is to have clinical champion to drive this kind of projects, and you obviously you've provided that energy and interest in that. What is the most, like, thinking about, you know, the past year for you and your team, what's the most compelling value proposition for you as a clinical leader, you know, to support this kind of initiatives? I mean, or what's the message to the audience here who are contemplating, you know, starting this kind of project? What is there for you?
Okay. Thank you for your nice words. But actually, during the last year, I will speak only for the leadership impact. There is question regarding the orthopedic and neurosurgery. I started to clear this way. The leadership actually added to the performance KPI for the physician that the rate of transferring to others to enhance the multidisciplinary care team. So this actually did a very good impact in our cases. Actually, the unit, there is 70% increase in the number of cases during 25 in comparison with the first quarter on 24. Regarding the surgery, there is increase by about 40% increase in the number of surgery. This is regarding the impact of our proposal in the business or on the hospital. So the leader are supporting us from as working as a leadership. First, communication. Actually, I started to communicate not by phone. I actually was used to communicate with all the member of the team and the other department on personal way, face to face, and attending with them some session for physiotherapy, some session for education. Second, also great support and education. I educated myself and teach myself by support from the quality team, and I asked a lot of things which I wasn't know. The quality team support me for this, so I educate myself first, then I start to translate the message to other team involved team. Third point, I was involving them and motivating them for any hospital meeting. I am nominating them by name for their effort and support of our care. Fourth point, actually, I am working with them and the team. Even my physician in the same area, we are increasing our number. We were only 1 spine surgeon, now we are 4. We have 1 pain management clinic, now we have 2 pain management clinic. Actually, when I supporting them and helping them to solve any obstacles or challenge that they are facing during their care or during their care for their patient, by communicating directly with the administration and the leadership, and actually most of this problem are solved with very limited time. So this motivate people to complete our proposal and motivate to increase the number and the project.
Thank you so much. I mean, I truly enjoyed our conversation, and I've been actually offline reminded by ICHOM team that you know, our time is up very soon. I know there's quite a few questions that were not answered, so I'm just want to reassure everyone that we will come back to you offline and we will provide those answers. I want to thank you so much, the team here, to joining us today and sharing the journey and the experience. And again, it's so great to have you virtually and see you again. So I will just be asking my iCHOM team if you could just share the final slides before the closing. Let's see if they're loading. I think the final maybe, so the few announcements, the next webinar, CMS Health Outcomes Measurement Journey, will be on Thursday, 26th of June. So please do dial in. It's free to attend. You just have to register. Next slide. This is information about iCHOM accreditation program. The team talk about, how they've been certified for low back pain, and they are first hospital in Saudi Arabia to be certified. If you are interested about our iCHOM accreditation program, want to know more, want to understand how to apply and how to be certified, please do check our webpage, or you can just follow this QR code. We are also encouraging everyone who are implementing our sets to join our implementation directory. So again, this is for us to understand who is using our sets. And, if we hear from you, hopefully we'll see you as well on this webinar, just as our team from Saudi German. And also in terms of the partnering with iCHOM, there's so many opportunities to work and to collaborate with us. If you are interested to become a partner with iCHOM, please do contact my colleague, Jose Delgado, and you can see his emails at this slide as well. And that just is to acknowledge all our partners. You can see it's a great group of collaborators, and I think it would be fantastic if you would join that partner list as well. So with that, I want to say thank you again, and I hope you have a great afternoon, great morning. I know we have some people from other time zones as well joining us today. So thank you and goodbye.
Thank you.